Good morning. Thanks for joining us this morning for the Ohio episode-based payment model update. My name is Karen Hoyt, and I direct payment innovation activities for the Ohio Department of Medicaid. I'm joined here today with several colleagues from both the Ohio Department of Medicaid and the Governor's Office of Health Transformation. We'll take just a second and quickly go around the room so that you know who's on this side of the webinar.
Monica Yanger with the Office of Health Transformation.
Greg Moody, the Office of Health Transformation.
Adi Kumar from McKinsey.
Krista Moss with McKinsey.
Teresa Hatton with the Office of Health Transformation.
Thanks much. That pretty much sums it up. We'll additionally be joined by Dr. Mary Applegate, who is the Medical Director for the Ohio Department of Medicaid, shortly. Unfortunately, because of the webinar setup, we can't go around and do introductions on your end, but I do want to take just a minute to thank you all for your continued participation and support of the SIM Payment Innovation Initiative here in Ohio. We understand that we have participants from the original episode design team joining us today. Additionally, we have members from any of our 6 CAGs, clinical advisory groups, who have helped us determine the clinical pathways for our existing episodes. So thank you very much for your participation and your continued support. Just a housekeeping note, during the webinar today, you should see a chat feature on the side of your screen. If you have questions about the information presented, please feel free to submit your questions into us. At the end of the webinar, we should have some time to go ahead and answer any questions that come through as time allows. We thought it would be a good idea to sort of get folks back together virtually here today to update you on episode model, where we are within the models. Of course, we have 2 different waves going right now, waves 1 and 2, to share timelines across the different episodes that are out there, and also to just enable you to see what different resources we have available. We have continued to add resources to both OHT and ODM websites. Additionally, we have some updated information along the episode pathways as well. So thanks again for your participation. We'll go ahead and get started. The first slide I want to project here is really just a recap. You all have seen this in your journey with us along the payment innovation road. This really just highlights the case for change in Ohio, why paying for value is needed. Ohio spends more per person on health care than all but 17 states, yet Ohio has a less healthy workforce than 29 other states. Moving forward here, again, this is a slide that should be familiar to folks, and I want to highlight where we are, or where we have been since 2013 in the pay for value column here. We've been able to align with our commercial partners in engaging folks to set clear expectations for better health, better care, and cost savings through improvement. And here's our 5-year goal slide, again, a familiar slide to many folks. While we'll be focusing mostly on episode-based payments today, and you see the call out on this slide on the episode-based payments, I want to take just a quick minute to touch base on patient-centered medical homes and the update on that. As you all know, we received a large federal award on innovation, and we have 2 different payment models going. The patient-centered medical home rewards enhanced primary care through better coordinated care. And just to call out a couple of things right here. We will launch in 2016 across all Medicaid managed care plans and the 4 largest commercial payers, rewarding providers to improve quality and reduce patients' total cost of care. Right now, we're inviting primary care physicians across the state of Ohio to provide us input by visiting and completing a PCMH provider survey. You can see a link here to the survey. We will also distribute the survey link to folks who are participating after the webinar has concluded today. For more information about PCMH, you can certainly visit the Office of Health Transformation website. We would greatly appreciate your input via the survey as it helps to better inform us as we continue to develop the care delivery model and the payment stream model for patient-centered medical homes. We anticipate the development of those 2 streams of work will be complete by the end of 2015 so that we can roll into 2016 with the patient-centered medical home care delivery model and payment stream. So we're here primarily to update you on episode-based payment model, and we have a specific example that we want to walk through today as well. It's tough to choose, of course. We have 13 different episodes out there right now. When we look at wave 1, of course, we have 6 episodes. We've chosen perinatal. We'll get into some of those specific examples as we move forward. But just again, here's another slide that will look familiar to everyone. It's a recap of our retrospective episode model and the mechanics therein. Just to highlight here really quickly, things in the top part of this slide, numbers 1 through 3, are meant to highlight that nothing really changes in terms of people getting care today. So patients are still going to seek care and providers still bill and are reimbursed as they do today. Then after the fact, claims data is analyzed, and that gets us into the lower row of this slide, numbers 4 through 6, where we're identifying the principal accountable provider, or PAP, who's held accountable for all episode costs. We're calculating the average cost, episode cost per PAP and comparing it to set commendable and acceptable thresholds. That allows us to determine eligibility for positive incentive payments or negative incentive payments. Again, another familiar slide for folks. This is the visual representation of our PAP distribution. This is the PAP curve for the retrospective threshold. This is our high-level picture of the episode-based payment distribution curve. And just a couple of things to highlight here. Of course, you see the acceptable line above which providers might be incurring negative incentives. The commendable line below which providers would be eligible for positive incentive payments. I'll note just a refresher for folks here. On the right-hand side of the curve, you see both green and blue vertical bars. Those are principal accountable providers whose costs are below the commendable line and who would be eligible for a positive incentive payment. The blues, however, are folks who have not met the quality metrics, and so they, by virtue of not meeting them, are not eligible for that positive incentive payment. The next slide is our elements of episode definition. For today, as I've mentioned, we've pulled out a specific example to better illustrate the episode pathway, but this is just a refresher, all of the different elements that go into the episode definition. So we'll move forward to the next one, which is our perinatal episode example. You can see here we have drawn out the episode triggers. We have, of course, for each episode, a pre-trigger, trigger, and post-trigger window. This encapsulates the entire episode itself. For perinatal, the pre-trigger window goes back, I believe, 280 days, before the delivery of the baby. And the post-trigger goes out 60 days past the live delivery. So you can get the full episode window there. The principal accountable provider for our perinatal episode is the physician or physician group responsible for the delivery. That's the billing provider or the contracting entity. And then, of course, you see the other components of the perinatal episode, including quality metrics, the claims included, potential risk factors, and exclusions. So we thought it would be helpful to walk through our pathway in determining what the episode, the pathway of the episode, and that ultimately leads us to setting thresholds and the commendable and acceptable thresholds on the PAP distribution curve. We'll walk through how we develop the final risk adjustment PAP distribution. This is our first picture in doing so. This is the episode, sort of the first step of the development. That is all the PAP unadjusted episode costs arranged across the PAP curve. These are the full episode costs. So when I mentioned before the pre-trigger, trigger, and post-trigger window, these are costs associated within the entire time frame of the episode, and it's before any adjustments have been made. The next step in walking through this pathway is to look at exclusions. For all of the episodes, we have exclusions. We have categories of exclusions that remain the same across all episodes. The particular exclusions per episode will vary. So you'll see here we have business exclusions, we have clinical exclusions, and we have a normalization process. You can see some examples, for example, third-party eligibility, dual eligibility, a PAP out of state. Those are examples of business exclusions for the episode. And then, of course, clinical exclusions for perinatal, just to call out a few, age less than 12 or over 49, cystic fibrosis, ectopic pregnancy. Those are clinical factors that would result in exclusion of the episode. And then lastly, just to mention that we have the normalization process. We want to remove any impact from medical education and capital expenses for facilities who may be receiving those payments because they don't really factor into the total cost of the episode care being delivered. Flipping to the next slide, you can see here our PAP curve has changed a little bit. You'll note that there's gray lines behind the dark blue lines. The gray bars refer to the original PAP curve. This is prior to the impact of exclusions and normalizations that I just mentioned. The navy bars in the front represent the average spend for the same PAP after those business exclusions and clinical exclusions are removed. Additionally, after the normalization, impact has been factored as well. For most PAPs, you'll see the average episode cost decrease. However, I do want to point out that for some, you'll note that there is now a blue bar that is above the gray line behind it. That's simply due to the exclusion process. For some PAPs, some of the episodes that were excluded were lower cost episodes, and therefore, by taking them out, resulted in an overall average higher episode cost across the episodes for a particular PAP. So the next step in the process is our risk adjustment. The risk adjustment model for perinatal, I just want to call out here, accounts for more than 70 risk factors. So you see just a subset of those factors on this slide here. We thought it would be a bit overwhelming to list all 70 on the slide. However, I'll mention that our detailed business requirements and our configuration files that are on the Ohio Medicaid website contain all of the risk adjustments as well as exclusions. So for a more detailed look, you can certainly hop on our website and pull down the detailed business requirements for the perinatal episode. The end result of walking through the risk adjustment factors gets us to this picture. This chart shows the original PAPs, again in the same location, with the original unadjusted spend prior to exclusions in gray. The navy bars in this picture show the average risk-adjusted reimbursement per episode. So we've gone through the business and clinical exclusions, we've gone through the normalization for med-ed and CapEx, and now we see the distribution with that risk adjustment. And you can see that there are both higher and lower risk adjustment costs across the original curve. We thought it would be helpful here to show you a picture of a couple of things. The top of the chart, the navy bars from the prior page have been reordered from largest to smallest. So this is one of the last steps in setting the overall PAP distribution curve for any given episode. This is the risk-adjusted PAP curve you've heard us talk about. Below that chart, at the bottom of the page, we're showing the average degree of risk adjustment with the PAPs in the same order as the top figure. So you can kind of compare, and you can see there's no correlation between the average risk-adjusted reimbursement and the level of risk for the providers. Once we've gone through the steps that we just did, we're able to study the variation between our high-cost episodes and compare those to the low-cost episodes. For perinatal, you'll see here we've called out a few things. looking at this PAP distribution, on the left-hand side, we've got the 10% highest cost PAP for the perinatal episode. And to the right-hand side, we've got the 10% low-cost PAPs for the episodes in perinatal. And you'll note here just a few things. The C-section rate for those 10% on the high-cost side is 37%, whereas the 10% low-cost are at 22% on a C-section rate. When we looked at the average number of ultrasounds, we see that there are 5 ultrasounds for the top 10% highest cost, and they're compared to 3 in the 10% with the lowest cost. And then, of course, following up here, our rate of follow-up visits, 79% in the high cost category and 75%. So as I mentioned at the outset, we thought it would also be helpful to provide you with some updates in terms of the timeline and launch of our performance period. We're nearing the stage at which we'll be entering into our first performance period for Wave 1 episodes. That's to begin January 1st, 2016. Here you see all of our Wave 1 episodes in addition to the principal accountable providers listed for each of them. The Wave 1 episodes were launched in March of 2015. Throughout calendar year 15, we have released reports, informational reports only, for each of these 6 episodes. And you'll see here Wave 2 is set to launch in January 2016. Similar to Wave 1, we'll go through a period of time by which informational reports will be released for Wave 2. We'll have that be a 12-month period so that folks can get accustomed to reading their reports, seeing where their performance falls along the PAP distribution. We will, just a note here, Medicaid is implementing all of these episodes. Our commercial plans have been asked to select for Wave 1 at least 3 episodes. Most of our commercial partners have selected total joint replacement and TCI in addition to one other. We were not specific in terms of which episodes they needed to select. And for Wave 2, we've asked that they select up to 4 episodes. For those, we asked if they could align on cholecystectomy, EGD, colonoscopy, and GI hemorrhage. Of course, there's no requirement along those lines, but we are working with them to see which episodes will be implemented. In order for us to keep pace with the number of episodes that we're implementing here, you can see this is just a visual representation of our governance or our framework. Many of you have seen some variation of this in the past. You can see on the left-hand side we've got our PCMH governance. Starting at the top, however, we have the Governor's Advisory Council on Healthcare Payment Innovation. This is a group comprised of numerous folks across the state. We've got payers, we've got large self-employed companies, we've got researchers, a whole host of folks that have come together on the Payment Innovation Advisory Council. Stepping down from that, we of course have our episode design team. Many of you participated in the episode design team or model design for episodes. And then depending on the particular episodes we're developing, we've convened our clinical advisory group to help us determine the best clinical pathway for each of the episodes. We'll continue to convene clinical advisory groups as we move forward in setting additional episodes for Ohio. Moving on, we've got our episode timeline. For each wave of episodes, the state's following a similar process. And we have highlighted here our Wave 1 process across the top. Each of our waves will start with episode design. This is the process that many of you were involved in. This is the convening of the clinical advisory groups. This is reviewing our clinical data in concert with the clinical advisory groups to inform the definitions around the particular episode. Next, we move into the implementation readiness mode. This is the finalizing of the risk adjustment model. Once the episode definition has been determined, and this is the preparation for the report as well. The third step here is the launch of informational reporting only. This is the 12-month period where providers receive 1 year's worth of informational reports. And then, of course, we move into launch of the performance period. This is episodes ending in performance period will be used to determine whether or not a PAP is eligible for a positive or negative incentive payment. And again, just to reiterate, for Wave 1, you see the star there is the beginning of our performance year for Wave 1. So that's January 1st, 2016. All right, moving forward here, this is a picture of our provider reports that have been issued. To date, PAPs for the first wave of episodes should have received 2 cycles of the report. And just within the last couple of weeks and probably into the next couple of weeks, reports for the next set will be going out. Episode reports are a very valuable tool for providers. This allows to assess their practice patterns and identify opportunities for improvement. Again, you have the picture here of the PDF summary report that goes out to everyone. I just want to mention here on the left-hand side of the screen as well, we've got all of our participating partners. We've got all of our Medicaid managed care plans, as well as 4 of the largest commercial payers in the state of Ohio. The reports that go out, you can see here, have overall summary information for folks. They're shared by the payers directly with each eligible PAP. So that means that currently, for example, in the or in the Medicaid program, providers or PAPs will receive up to 6 reports for Medicaid. That's 1 fee-for-service report and up to 5 reports from Medicaid managed care plans, depending on with whom they contract. In addition to the summary PDF report that is distributed, we also distribute a complementing reports in a CSV file. The CSV file includes information on both valid and excluded episodes during the reporting cycle. So we feel that these files are a very useful tool in addition to help folks drill down and better understand sort of key sources of variation. For example, you can use the file to look at the breakdown of average risk-adjusted spend by the rendering providers. You could also look at the impact of specific services. For example, we have breakouts within the CSV file that delineate costs associated with inpatient, outpatient, pharmacy, and so on. Additionally, based on some feedback we received from actual providers early on in our technical assistance efforts, we have added in quality metrics or performance metrics for each of the episodes. So line by line in the CSV file, you can look at which quality metrics were met and which weren't met for each of the particular episodes. Additionally, you'll be able to tell which episodes were included versus excluded from this file. So I mentioned that we had some feedback from providers on the reports that were going out. We've made a concerted effort, along with the commercial and Medicaid managed care plans, to listen to providers in terms of what's working well, what could be better in terms of the reporting information as we move toward the performance year. And based on this feedback, starting in 2016, the episode reports will follow a similar but slightly updated format. And you can see that format updated here. At the very top of the report is a set of eligibility requirements that helps explain how the volume, spend, and quality metric performance impact your eligibility for positive and negative incentive payments. And then additionally, for the 3 episodes for which Medicaid is launching in the performance period, to which payment will be attached, that's asthma, COPD, and perinatal, you'll see the PAP curve is colored as it is here with thresholds that are drawn over top. So this is where, beginning in 2016, providers, you will look to see where you fall across the PAP distribution, and you'll be able to see that visually with both the commendable and acceptable threshold lines drawn as well. One more thing to note for those of you who are familiar with having received the provider report, an additional change in 2016 will be that you will only need to have one valid episode in order to receive a report. Prior to this time, it was 5 valid episodes in order to receive a report. Also included in the reports, again, as I had mentioned, were information on quality metrics. So not only in the CSV files, but also a page in the PDF file will outline where a provider is in terms of quality metrics. Now we have quality metrics that are both associated with being tied to the positive and negative incentive payments, and then we have quality metrics that are reporting or informational only. So both of those are included in the report and delineated as such. The next step in terms of our journey in developing the episodes was to set thresholds for quality metric performance. And you'll see here that we've included the threshold information for you today. Ideally, our goal was to set the quality metric thresholds at the top quartile of current performance to encourage delivery of high-quality care. However, as we got into the data, in order to ensure the majority of providers would be eligible for gain sharing, we had to adjust that process a bit. And so where we landed for year 1 is that the quality metric thresholds are set at a level where 75% of providers would be passing based on prior calendar year 14 data. So we took data from 14 and we looked at who would have met the quality performance metrics, at what percentage rate would we have to set them in order to allow 75% of providers to be able to pass the metrics. It was important to us to do that so that we could encourage folks to get out there and take a look at the quality metrics, and we didn't want to disincentivize people from the episode-based payments because simply by virtue of not being able to meet the metrics. So you'll see here the thresholds for quality metrics are quite low for year 1. For example, asthma, our first quality metric is the follow-up visit rate. It's set at 28%, whereas the controller medication prescription fill rate is set at 26%. By setting them at those percents, it allows us to set the bar so that 75% of the providers would pass the metrics. You can see the metrics, the threshold metrics for COPD and perinatal as well. So moving on in our pathway here, setting thresholds for Wave 1 incentive payments was the next step. This is gearing up again for the beginning of the performance period starting January 1st, 2016 for Wave 1. So a few notes here about our process in setting threshold levels. Ohio Medicaid will set the cost and quality thresholds for all Medicaid managed care plans. So across the fee-for-service program as well as the managed care program, the Ohio Department of Medicaid set the cost and quality thresholds. We set one acceptable threshold for all of Medicaid so that 10% of the providers are above the acceptable threshold, assuming no behavior change. Additionally, we move forward from that process, and then we set one commendable threshold for all of Medicaid so that it's budget neutral after the positive and negative incentive payments are taken into account. Additionally, a note here on the payments for Ohio Medicaid, again, including the Medicaid managed care plans, the percentage of the positive and negative incentive payments for PAPs will be 50%. And payments are proportional to the non-risk adjusted payment for each PAP. And one note here, again, across the program, we're using the same methodology to set thresholds for all of the episodes, although of course they are specific per episode. And here you see a picture of the actual thresholds themselves. So a note here before I talk through this slide. These are the projected acceptable and commendable thresholds subject to inflationary adjustment based on an actuarial review. So these thresholds right here are not adjusted for inflationary purposes yet. They will be within the next 4 to 6 weeks, and we will update the information. This is all information that will be on the Ohio Department of Medicaid website and will be updated accordingly when it's available. The threshold values shown here are based, again, on the risk-adjusted episode reimbursement versus what the provider is typically paid for services included in an episode. These should be used in conjunction with the average risk-adjusted reimbursement values included on quarterly reports that you've already received. So for PAPs who have received quarterly reports already, you could take your most recent quarterly report and understand whether or not you would be eligible for a positive or negative incentive payment based on your current performance. So just to quickly run through these, on the asthma episode, the acceptable threshold, or the threshold above which a provider would incur a negative incentive payment, is $372, whereas the commendable line below which a provider would be eligible for a positive incentive payment is $292. You may all recall that we also have a gain sharing limit for each of the episodes. You see those listed here as well. That's the point below which we would not expect folks to have episodes necessarily that can be delivered, also keeping into account quality factors. So you'll see here for COPD, the acceptable threshold is $1,087, whereas the commendable threshold is $683, and perinatal, $4,405 for the acceptable threshold and $3,169 for the commendable threshold. So here we're back to our PAP distribution curve. This is the risk-adjusted average spend with all of the PAPs represented by the vertical bars. The difference here is that we've now applied the acceptable and commendable and gain sharing limits to this. And so we'll walk through this for a minute here. We have roughly 380 providers in total in the perinatal episode. You'll recall that we set the acceptable threshold such that 10% of the providers would be above the acceptable threshold. So that gets us to 38 providers who are above that. That represents episodes that equate to 3,310. So of the 38 providers, there are just over 3,000 episodes that are above that acceptable threshold. The total negative incentive payment amount represented by those episodes is $424,000. Moving to the right-hand side of the distribution, you can see we have those who are eligible for potential and positive incentive payments. Those are providers who are below the commendable threshold. In this instance, it's 45 providers representing 3,220 episodes. And again, because we set the overall episode to be budget neutral across the Medicaid program, you can see here the total positive incentive payment amount is also $424,000. So that's what the distribution looks like across the entire PAP curve. We thought it might also be helpful to call out an example of a positive incentive payment, how we would actually calculate the payment to a provider. So you'll see here there's a call out for one particular green bar representing one PAP. The average risk-adjusted spend for this particular provider is $2,471. That is $466 below the commendable threshold. You'll also note, because we've chosen a green bar, this is a provider who met the quality metrics as well, and so therefore we'll move forward in calculating the actual positive incentive payment. The $466 represents 19% of the PAP's risk-adjusted average reimbursement, the total again being the 2,471. That 19% is then applied to the unadjusted average episode cost for each of the 15 episodes. So this provider had a total of 15 episodes, and so we're applying that percentage to all of the episodes. We then, as I mentioned earlier, the gain risk share percentage for all of the Medicaid program is set at 50%. So we multiply that by 50% to get a total of $6,401 in total positive incentive payments for this provider. And here we have an example of calculating the potential negative incentive payment as well. In the interest of time, I won't walk through this one. The calculation is the same as the positive incentive calculation. Also, I will just note that these slides will also be on the Department of Medicaid website, available online at some point this week as well. So moving forward, we have updates for Wave 2 and some key sources of information. This slide is familiar to you. Of course, we went through where we were with Wave 1 a few minutes ago. This is just a call out that for Wave 2, the reporting only period begins in 2016. So also in 2016, we'll be starting the design of Wave 3 episodes. Specific episodes have not been selected yet. The list of 7 episodes is likely to include 2 to 3 behavioral health episodes. So that's in the Wave 3 category down below. And you'll note the pre-work that has been done on Wave 2 in terms of the episode design, implementation readiness. We brought all the CAGs together through the spring and into the summer this year. So we're in good shape to move into our reporting only period in the beginning of 2016, which sets us up nicely to start the performance period in January of 2017. All right, and then nearing the end here, these are the materials that are now available online. So there are 3 types of files available for Wave 1 and now for Wave 2 episodes as well. We've got episode summary definitions, 2 pages. These are 2 pages that summarize the key elements of the episode definition. We went through this with perinatal earlier in the presentation. It's got the pre-trigger, trigger, post-trigger, who the PAP is, the codes to bill, and etc. We additionally have detailed business requirements for all of the episodes. These are detailed Word files, and they include all of the specifics required to code the algorithm for any given episode. And I'll note here that on our website, we've rearranged it just a bit. Episodes are grouped by wave. So we've got Wave 1 episodes and then Wave 2 episodes. All of these details will be hyperlinked to the particular episodes from the website as well. We also have the detailed code sets, which is the Excel file, including all the specific diagnoses and procedure codes for the particular episode. Yet to come in short order will be additionally the threshold information that I just reviewed for perinatal, but for all of the Wave 1 episodes for which we've determined. We just wanted to run through quickly here where you can find additional information for folks who are looking for it. As I just mentioned, here's the screenshot of our redesigned website at Ohio's Payment Innovation website. Again, you've got episode quick reference. Additionally, we have frequently asked questions, and then of course the Wave 1 and 2 detailed information I just went through. I should also note here we have the risk adjustment methodology posted online as well. So for those who want to better understand the process of risk adjustment, we've got a file for download there as well. And then moving on, we also have a link here for the Governor's Office of Health Transformation. where you find a wealth of information about payment reform and payment innovation across Ohio. We encourage you to visit the OHT website for additional resources, not only episode-based, but also a lot of detail around patient-centered medical homes. We've got updated slide decks from just a couple of weeks ago that are on the website detailing PCMH work as well. There are several presentations and documents from SIM overviews to the detailed analytics that inform the episode design process. And I think that gets us to the end of the prepared documents. Folks here have been taking in questions as we move along, and I think we can move to those.
Thanks, Karen. Again, if you would like to ask a question, please use the chat feature on the bar for the webinar. The first question we have is, on reporting, is it based on calendar year or state fiscal year? So the episodes are based on a calendar year. Particularly for the first 3 episodes, Medicaid is linking to payment for the performance period starting in January 1, 2016 through the end of December 2016. And performance will be assessed in 2017. This will not initially occur until the middle of 2017 so that we can incorporate additional months of claim submissions following the end of the performance period. Next question. Is follow-up visit for perinatal, which is a quality metric, the postpartum visit? Yes, the follow-up for the perinatal is the postpartum visit. So just a quick clarification on that. What is meant as a postpartum visit is the follow-up visit. Next question. Related to number of episodes, 1 is needed to get a report. Are 5 episodes needed to participate in gain share? That's correct. Principal accountable providers, 1 valid episode, meaning it is not an excluded episode, will get a report. But at the end of the performance period, a principal accountable provider, or a PAP, must have at least 5 valid episodes to be eligible for a positive or negative incentive payment. Next question. How do you determine the principal accountable provider? The principal accountable provider, the PAP, is specific to each episode definition and is based on a specific claim that triggers the episode. And so you can find this information, as Karen showed you, on the Ohio Department of Medicaid's website, where it shows you the definitions for each of the episodes. It defines the patient journey, which includes who is the principal accountable provider, what is the trigger window, etc. Next question. Will normalization for Med-Ed be applied to all episodes? That is correct. The normalization will occur in all cases at this time. Next question. Aside from the website, what other educational materials are available? Right now, we have, again, a plethora of information that is available both on the Governor's Office of Health Transformation's website and the Ohio Department of Medicaid website. If you have additional questions after viewing this information, you are more than welcome to contact either Karen Hoyt or myself, Monica Yinger, or follow up with additional questions that you might have. And that's on a various number of issues, which include where do I find my report, maybe some questions on how to read your report, etc. Again, there are also many materials available on the Medicaid website, specifically related to the report. Next question. You mentioned that for any one episode, each payer outside of Medicaid will be providing their own data to the individual principal accountable provider. Is there a plan to consolidate the reports in the future? So we've certainly heard from many providers that this would be much easier for a provider to receive a single report with multiple information from plans. We are certainly considering what this might look like and possibly what it would take to do this in the future. Next question. How will payments be normalized for impact of EAPG and APRDG rebates in 2016? The inflationary adjustment for the threshold is based on the adjustment used in the rate setting process that takes into account policy changes for Medicaid and as well as fee schedule changes as well. Next question. Will detailed claims data be made available to principal accountable providers? Currently, there is limited information that can be gleaned from the case summary level, for example, emergency department visits. Right now, we are providing, in addition to the PDF report, the CSV file, which I think is what you're referring to in your question. We don't have plans to include additional information at this time, but if you have suggestions on what you would like to see in a CSV file or other information you would like to see specific to the claim, we are more than open to your suggestions on how and what it should be included. Again, if you would like to ask a question, please feel free to use the chat feature in your bar. We do not have any additional questions at this time. Okay. Well, thank you again for your participation in this webinar. We hope you found it helpful and informational. Again, also a number of resources available in the Governor's Office of Health Transformation website and the Ohio Department of Medicaid website.
Great. Thank you very much. We will follow up with a survey link for folks that are interested in participating in the PCMH provider survey. And again, we greatly appreciate your continued support of the payment innovation efforts in Ohio. And for those of your peers and colleagues who are not able to attend today's webinar, we are recording this session and it will be posted online. And we'll make sure we send that link out to the group that received the original invitation as well. Feel free to share this again with your peers and colleagues who have been involved in this process and those who have not and are interested in wanting to learn more. Thanks so much.